us today on the World Menopause Awareness Month and the World Menopause Awareness Day. Today, we have our guest speaker, and it is my pleasure to introduce Dr. Dorcas Mushiri. She is a distinguished consultant obstetrician and gynecologist, a researcher and educator, and she has a wealth of global experience with practices on women's health between Kenya and the UK. She is contributing to both clinical excellence and advancing medical research, and is currently pursuing her PhD at the Imperial College in London. Dorcas brings a unique perspective to the intersection of clinical practice and academia, laced with lots of passion for women's health. Join me in welcoming Dr. Dorcas Mushiri. As we go through the webinar today, we will also be sharing a feedback form that we are happy to have these conversations and interactions with you. Welcome, Dorcas.
Hi, I hope you can hear me, Muthoni. Please confirm and at least check if the other participants can. All right, I see fingers going up, so that's really good. We had a bit of a technical challenge. We are trying to multitask across borders, but that is the essence of our education and training. So we'll get right into it so that we don't waste any more time. And as Muthoni has mentioned, there will be a feedback link. I have thrived on being told what goes well, what could have been better, and what we can improve on. And I hope that this webinar series continues to do that as well. I'll start off this conversation first by recognizing that even though this is World Menopause Awareness Month, we have been running a series called Beyond the Pause series. And our lecture today, as you all know, is a premature ovarian insufficiency. But I want to take some time to reflect on other patients or other people who will be struggling with other things that we are recognizing this month. Top of that list is breast cancer, and we're going to have a conversation about that because our patients are women, so we don't want to forget or overshadow that bit of their health. But also recently learned that it's also Liver Cancer Awareness Month, which was quite interesting for me. The liver is very important in processing estrogens and plays quite a big role in how we make decisions on giving medications to our women. So I don't want to take away from that during this month. I start off by using a quote from Professor Anne McGregor, who has spoken December 2018 at a forum in London. And some of you might not know who she is, but she's a professor of headaches. And I was quite impressed that people are so specialized. They focus on headaches or specific conditions. And the reason I chose to use her quote, "We can believe what women say," is because even in this day and age, and I remember in my practice as I started, there are so many women who would come and they would say things that may not have read textbooks or things that we've not had. So I remember patients, and I know this forum will have people who are not necessarily Kenyan, so I will try and interpret some of the Swahili words or sentences that I use. But I know that there are women who have in the past come and said, "I feel things crawling under my skin. I don't know how I'm feeling." In Swahili, if you know that, they say, "Sijui venye nasikia." So you ask them, what are you feeling? And they really don't know what they're feeling. But when they say that they feel insects crawling under their skin or they feel their heart is racing and beating too fast, Professor Anne reassures us and allows us as clinicians to believe what women are telling us. So we'll get right into it. So I do like to play around with gadgets and tech. I am not of the Gen Z era, I must disclaim, so I am learning. I'd like you, if you can, please take this QR code onto your phone for those who have QR codes, or if you go online to slido.com and put in for the event the number 3542329. I'll allow you a little bit of time. The reason I use Slido is it's very cool. I like to ask questions and make this as interactive as possible, mostly because I can't see you. So I am hoping that all 355 of you are somewhere listening in and are able to participate. So if we can quickly do that, because the next slide is an actual question that I would like you guys to participate in. And that question is, what comes to mind when you hear premature ovarian failure? I would like to just see your thoughts. I'm going to give this about 30 seconds. Write whatever comes to your mind. It can be trauma, it can be young, whatever comes to your mind when you hear premature ovarian failure. The QR code is still at the top. It'll just take a little bit of time. Yeah, I can see early menopause. Infertility, problems, premature menopause, below 40 years, early infertility, life-changing. I like that. We'll talk a little bit, actually a lot, about the psychology of premature ovarian insufficiency. We've only had about 13 of you respond. There's 370 of you. And I'm lucky, you're lucky that it's not a class lecture, so I can't pick on you, but I'd like to see a few more responses. That's the QR code for whoever is joining us and has missed it. So if you go to slido.com, put in the event number if you're doing this from your computer, 3542329, or use the QR code. And our question is, what's coming to your mind when you hear the words premature ovarian insufficiency? Depression, psychological trauma, thank you. Early menopause, premature menopause. Let's keep it coming. Early infertility, quite good. Okay, so we've got 20. If we can get to at least 50, then we see what are the big ones. No babies. Yeah, keep them coming, keep them coming. Premature menopause below 40 years is quite big. Infertility is coming to a lot of your minds. Hot flashes, very nice. I can see we're exploring other ways, but even if you feel the first word that comes to your mind is something that's already come up, don't feel shy, just put it in. Okay, so we've got about 25 people. Anyone who hasn't been able to screen, that's the QR code. And if you go to slido.com, the number is 3542329. The reason I'm asking to do this is because there's another question coming up. So I think this is good practice. Psychological impact, there's cancer, adrenal insufficiency, that must be a physician, can't be a gynecologist. I also want to tell you, I can't tell who is answering what, so this is very anonymized, so I don't get to see who said what. Good.
We also have some responses on the Q&A.
On the Q&A, yeah. If you can add those to my list. Is it anything different from what I've mentioned?
No, it's basically early menopause and premature menopause.
Oh. I like that. Extreme fear of infertility. Yeah. Havoc ahead. Family history, yes. Family breakdowns, yes. I've seen mental health breakdown, lack of estrogen and progesterone, when ovaries stop working normally. Excellent. You guys are really with it. I like this. I like this audience. Okay. All right. So we'll go on to our conversation. There's about 40 of you that have responded. Incompetent ovary. I'm trying to peep behind my screen so that I can also see what's coming through. All right, I think you guys have done really well. I'll ask again for that QR code if you've just joined us. And if you go on slido.com, the number is 3542329. So you'll be able to answer the next questions when we get to it. I see no babies. I see irritability. Yeah. So I can see that a lot of us have fertility at the top of our minds, but you can see some other things are also coming through in terms of mental health. A lot of depression there. We're worried about cancer. So whether it's that they're getting cancers early or it is the cancer that is causing the premature ovarian insufficiency, we are going to have a chat about that. Good. So we'll go on with what I normally do. My job is a women's health specialist and I work in infertility, and I thought this would be a nice place to sort of start with a case presentation. And I want to disclaim that this particular topic is actually one of the most multidisciplinary, interdisciplinary topics I've ever had to engage in. So the fact that I give a case presentation that is fertility related does not take away from the conversation of how in-depth the disciplines are involved. But this is a couple that I saw literally last week. And they're 37 years old, both of them. The top bit is a semen analysis, fairly standard, fairly straightforward. And I just wanted to highlight because the man and the lady in this conversation both had significant issues. They've been married for 5 years and had been trying to conceive for 5 years. And if you look at the concentration of the sperm, that is 0. And the total sperm number is also 0. So they already have, big problems to be thinking about. I'm having to be the clinician who breaks this news. And I want us to focus on what is called the anti-Mullerian hormone down at the bottom. This is an ovarian marker for those who may not be aware about ovarian fertility marker, and we use it a lot in fertility when we are trying to ascertain what kinds of treatment to offer our patients. And for this lady who is 37 years old, her AMH should be the range of 4.1 to 58 picomoles per liter. That's how we normally report it. And I put a really sad face because that's what normally happens in my clinic when I have to break that news. Her AMH level was 0.5 picomoles per liter. More importantly is, it might not be able to see that, but behind here we do what is called the atrial follicular count. We do a transvaginal scan. And what we are looking at is the ovaries and what they're producing for that month. So just to refresh your minds on what happens in a menstrual cycle, because I presume there are people who are not in gynecology, haven't refreshed this for a long time. The cycle is based off the body producing estrogen and progesterone. Estrogen is the initial phase of your cycle, and then the progesterone comes after the ovulation has happened. So when we're doing our scans, we want to catch the patient when she's around day 2 to 5 of her cycle, and you want to count the number of follicles that you're anticipating you would be able to stimulate and get some eggs from if you are doing IVF, for example, or if you're giving some tablets to help with induction. So once you're starting off on day 2 to 5 with 0, then it is unlikely that she's going to have anything for that month to use for treatment. So I want you to place yourself in the situation in yourself as a clinician seeing a 37-year-old couple whose ovarian results like that have been trying to conceive for 5 years. Or place yourself in the shoes of this 37-year-old who's meeting a clinician coming to try and conceive. And this is the news that I have to break to them. Now we are back to Slido. Since we know the drill, and we have this QR code. If you have not yet joined, then join at slido.com. It's the same number, 354-2329. And this time, I hope that we will do it slightly faster. The question we are asking is, what do you think is the definition of POI, premature ovarian insufficiency? So I'll give you a couple of minutes to answer that. So nearly 90% of us think it's the first option. Cessation of periods. Oh, sorry. Oh, I might have leaked the answer. Right. Okay. So yeah, I can see we are still moving. Some people have started to change their minds when they saw the answers. Okay, we're just about 23. Again, we'll try and get this to 50 if we can get it clear quickly. There's no answers, there's no marking scheme for this thing, so don't worry. And again, I can't see you and no one can see who it is. So don't feel shy. You know, if you're not sure, click on something that sounds remotely familiar. Okay, we're doing well. We're nearly 74%. The QR code is on the left. What is the definition of POI, premature ovarian insufficiency? I presume it's the same 35 people who had logged on before. So if any of you have come late, that is a QR code for what we're using to just make this slightly interactive. It's a slido.com. If you're on your computer, then you can join in with that code 3542329. Okay, so in the interest of time, we will move ahead. So, and now we officially start the webinar. All the rest were sort of games, fun and games. So premature ovarian insufficiency is a clinical syndrome that is defined by loss of ovarian activity before the age of 40. And it is characterized by menstrual disturbances, which is anything from amenorrhea to oligomenorrhea, meaning they can be having no periods at all, or they have periods that are quite intermittent. And what is distinguishing is the raised gonadotropins and low estradiol levels. Now, for our non-gynae, non-endocrine colleagues, gonadotropins is follicular stimulating hormone, and LH, which is the luteinizing hormone, which interestingly in pure menopause, then those also get elevated and you also have low estradiol. The difference between this premature ovarian insufficiency itself is that the periods have completely stopped. So that's one of the differences when you're talking about terminologies. Premature menopause means the periods have stopped before the age of 40 and they've completely stopped. They don't have a period for more than a year. They have raised gonadotropins and they have low estradiol. Slightly different from premature ovarian insufficiency, where they may have periods occasionally. Sometimes it's even twice or thrice a year, and they happen to be under the age of 40. This characteristics, if you look keenly, menstrual disturbances with raised gonadotropins, if we flip the low estradiol into high estradiol, it becomes polycystic ovarian syndrome. So as we continue to have this chart and sort of thinking through that, I want you to also imagine a 30-year-old, for example, who's come and she's had irregular periods or some menstrual disturbances. You do a test and follicular stimulating hormone, LH, is high, but the estradiol is high, then she is polycystic ovarian syndrome. Now, why is that important? All these women get the same symptoms. They will all have some hot flashes. They will all have symptoms that we're going to be discussing. So I want to take us back a bit in history. I like history because it tells us how far we've come. Fuller Albright was an endocrinologist, and in 1942, he started to notice a pattern in some women, and he called that primary ovarian insufficiency. So the POI from 1952 was primary ovarian insufficiency, as opposed to what we now know as premature ovarian insufficiency. And he described the symptoms and how to test, but later people felt that primary ovarian insufficiency was not being able to differentiate whether the problem was primarily from the brain or it was an ovarian problem. So there was lots of changes that ended up with premature ovarian failure. And in recent times, we've stopped saying premature ovarian failure because it gives our patients quite a lot of psychological problems. They feel like they have actually failed in life, and hence the move to premature ovarian insufficiency. Now, the differences between premature ovarian insufficiency and early menopause, like I stated, is menopause, there's no period whatsoever. Primary ovarian insufficiency, they may have periods. And I just wanted to raise that this should not be confused with primary and secondary amenorrhea. The prevalence in the Western world is 1 to 3%. And I say Western world because we don't have data in our settings. It varies with age. And if you look at that, you can see that there are ladies who can be between the ages of 18 and 25, whose ovaries are already insufficient, and all the way up to the ages of 35. Why do I find this topic important? In recent times, as recent as last year, Asia and China have reported a 15 to 30% prevalence for premature ovarian insufficiency. And the latest paper we've got is from a lady called T. Leon and her team. They've used demographic surveys from lots of countries in the world, and their conclusion is that the trends indicate an increasing prevalence of early and premature menopause in low and middle income countries, in particular in sub-Saharan Africa, South and Southeast Asia. And that's why that's important for me, because I am from a low middle income country in sub-Saharan Africa. I want us to quickly go through the physiology of estrogen just as a refresher. It's usually secreted in the ovary. It's a hormone of the females. That said, women also have testosterone among other hormones. And some of it gets produced from the corpus luteum, which is where the egg has been released from in the month. It can also come from the placenta, the brain, the skin, liver, and heart. And just as a way of revision, there are three main forms of estrogens. Estrone, which is E1, is the estrogen of menopause. Estradiol is what you would normally have in reproductive cycles, and estriol is the estrogen of pregnancy. All these estrogens usually increase angiogenesis and vasodilation. So that's a good thing. They protect the heart. You reduce oxidative species, and you also reduce fibrosis in blood vessels. So I'm starting to sort of take you through the importance of estrogen and why we are concerned about it. Estrogen is bone protective, and it's also brain protective. What do we know at the moment when we think about our patients? So I'll try and center a lot of this back to the patient. 71% of women have reported that they were unhappy with how a diagnosis was given to them. So remember my patient who was 37 years old, coming as a couple, coming to conceive. I am having at that point to have to break the news that first, your ovarian function is very low. Second, we do need to investigate whether you are getting into the menopause or not, because the AMH is not what we use for that diagnosis. And then third, you're going to be having to send them home with information that they were not prepared to have. So you will have to have conversations about their heart, their bones, their brain, and that's not what had brought them. So 71% of women have actually reported, I didn't like how this information was broken down to me. 50% of women who have had bleeding abnormalities had to seek multiple help from physicians before any testing was offered. So I want you to just imagine if a lady comes and she says, you know, my period has not been present 2 or 3 months, how frequently do we think, let me investigate, and with a view of premature ovarian insufficiency, especially if she's not presenting with infertility. Spontaneous conception can happen, and women are not necessarily sterile. And in approximately 50%, there will be some activity of ovarian activity. Now, these ladies also then are on the other spectrum. You've been told that your ovaries are not working very well. You've been sent off with inadequate information, and then you get pregnant when you had not planned to get pregnant. It's a small number of women, but that happens. And like I said, their symptoms are irregular and absent periods, hot flashes, mood changes, and infertility. So these ladies will still get the full spectrum of what we know as menopause. There's currently nearly 50 symptoms that have been described, attributed to low estrogen and menopause. So all these women may go through all those things that we discussed, including low libido, dry vagina, anything that you can attribute to menopause can be attributed to these ladies. So again, I want to take you back to that 37-year-old who's come with infertility problems, but is being unable to have sexual intercourse with her partner. It can be quite distressing for both of them. So again, taking you back to patients, these are people we see quite frequently, and sometimes it doesn't occur in our minds. 30-year-olds, 40, maybe under 40. I want you to think about a woman who's had a uterus removed because of PPH, hemorrhage at an emergency cesarean section. All these patients are real. One whose mother has had breast cancer at the age of 40, she's worried about her own breasts now. These women tend to have what is called the BRCA gene. And when we do send them for testing, our recommendation from obstetrics and gynecology side is that we should, as the breast is being sorted, we should remove their ovaries and their tubes because they are also at risk of ovarian cancer. Imagine a lady who's like this, who has also been trying to conceive for 5 years, a young lady. The other one who has had an ovarian cancer at the age of 19, and at that point she received chemo and radiotherapy. I want you to place yourself as a clinician seeing a patient who you're giving chemotherapy and radiotherapy at the age of 18. How frequently do we discuss their fertility options and what is coming ahead in terms of all those things that you had mentioned on the slide, depression, inability to conceive, all those things. And I want you to think also of the more common things that occur for us in our setting, hysterectomies for uterine fibroids and treatment for uterine fibroids. This could be anyone's mother, a sister, a neighbor. I just want you to imagine these women. The reason I say imagine is because when we are clinicians and scientists, we put these things, when we say causes, for example, we put them in a list, but trying to put it back to a patient and associating with a patient when you're seeing it on a list like this can be quite difficult. This list has been created, it's a global list, and chromosome and genetic abnormalities, for example, I'm not very sure how many of us even get the opportunity to, say, screen for Turner's syndrome. I get to screen for it because I'm in fertility, but I'm not sure how many physicians, how many radiologists, radiographers would be testing for Turner's syndrome. And there are so many other genetic conditions. Galactosemia, I want you to think, when is the last time you heard that word, galactosemia? Have you heard it recently? Do you know about bone metabolic protein or something like that? There's so many genetic abnormalities that we don't get to screen. We don't have capacity, or maybe we do, and they're too expensive to screen. I want you to think about autoimmune patients. These generally tend to land with the physicians. So SLE, Hashimoto's thyroiditis, all those autoimmune conditions will also directly affect the ovary. There's a condition I not laughed in that way, but recently thought about the autoimmune polyendocrine problems that give you diabetes and Hashimoto's plus ovarian insufficiencies. Environmental, we don't have data available at the moment from East Africa or even Africa as a whole, but the Chinese have been quite active in looking for environmental problems, and they are producing quite a bit of data in terms of what we're calling BPAS and endocrine disruptor chemicals. They seem to be having quite a big problem with early periods, early menopause, early polycystic ovarian syndrome. So these are things that we need to be sort of putting at the top of our minds. Chemotherapy and radiation, very common for us. And I had asked pediatricians to attend this because we do have children who have been offered chemo and radiotherapy and are survivors of cancer. And they present to us later in life with inability to conceive or other menopause-related symptoms. Infections for us, most common is tuberculosis, even though malaria has also been implicated in this. Surgical colleagues, we want you to think of anything that is around the pelvis, including ruptured appendices, what we do during that procedure. But from a gynecology perspective, when we are thinking broadly, we always think of the big things that have removed the ovaries. And I'm not even sure when we do remove the ovaries for whatever reason, what kind of conversations we've had with women before we have those procedures. But what is more sort of benign is things like uterine fibroid embolization that's done by our radiology colleagues. And we do have evidence that that procedure, whilst very effective for treatment of fibroids, can affect ovarian function. Hysterectomy, and this I had a patient quite recently having hysterectomy, but the ovaries are being left in situ. And as far as she was concerned, she was very happy she will never get periods again. The conversation that has not been had, though, is that she will probably get into premature ovarian insufficiency and premature menopause earlier than what we would expect, which is about 51 years. So when you're going to do your hysterectomies, please have these conversations. Endometriosis is quite common. It's on the rise, even in Kenya. And those surgeries are quite, I call them pesky, because sometimes you're just going in to remove an ovarian cyst and you find that it's so adherent to the capsule of the ovary, you have to come out with the full ovary. So whether you warned your patient before that surgery that this might happen. And a lot of it is unidentified. We are still doing a lot of research that gives us problems when you can't answer the patient's questions on what has caused this. The diagnosis of premature ovarian insufficiency, this slide, when I made it, I felt quite sad about it because it actually says proper diagnostic accuracy in POI is lacking. And that's what is available at the moment across the world. The reason we say diagnostic accuracy is because once a patient presents to you, there's no one-stop shop test that you can do and make a diagnosis. You've got to do a follicular stimulating level hormone at the very least. It has to be more than 25 international units. And then you've got to send her away and bring her back 4 to 6 weeks apart. Again, when we are thinking about our local context, how many patients are willing to go and come back? So that's one of the problems that we have with the accuracy of the test. That said, there are other ways to also, or additional tests that can be added. They're valuable, but they're not diagnostic. Like I mentioned, the anti-Ovarian hormone test and the luteinizing hormone, as well as screening for all the other problems that may present in menopause. This, for me, is a big problem with the psychology of premature ovarian insufficiency. Again, taking you back to most of these patients are young. They're presenting at a time when they're not expecting this news. So there's usually a shock of a completely unexpected diagnosis and confusion. I have had patients who have gotten angry, they get depressed, they're in total sort of mental disarray once you're starting to have this conversation. So I do recommend that if you find yourself in this situation, better to have someone else sit with you as you break the news, ask the patient if she can come with someone so that you can have conversations, and always offer counseling if possible at the time that you're breaking this news. They then start to have the stigma, and for our communities, I know that that is quite common. I say our communities, that said, even where I work at the moment, the stigma is there that you will be unable to conceive. The possibilities of conception are quite low. And then the worries that come with heart problems, bone problems, and dementia and brain problems. And that mental health, even though at that point they may not be having bone cardiac problems, the mental health has affected a lot of ladies of this age. They are unable to establish proper relationships that are long-term. Their esteem becomes very low. They see themselves as low, as not important people in society because they are not able to conceive. And if they have had a family history, where this is quite common, a family history, then they've seen the progression, especially in recent years where their mothers were not receiving treatment. They ended up with cardiovascular problems or on a bed with the broken bones. And that's how I describe premature ovarian insufficiency as a public health issue. Because if you think about heart problems, we know that, for example, prior to menopause, men get diagnosed with heart attacks more frequently and earlier than women do. But once women get into the menopause, they seem accelerated towards heart problems after the age of menopause. In that time, there's usually lipid disorders, hypertension, type 2 diabetes, obesity is on the rise. Inactive lifestyles, our patients are becoming more and more sedentary and they don't want to move, or they don't believe that it's in their genes for them to be able to move. But even more is things like smoking. And while that may not be properly obvious in a place like Kenya or Africa, I know that there is increased risk for smokers, even if it is passive smokers. And there is increased activity of the sympathetic nervous system with high oxidative stress. In turn, increases inflammation and reconstruction of arteries. And that's what eventually lands us with hypertensive diseases and cardiovascular problems. Reduced bone mineral density is very likely to indicate an increased risk of fracture later in life, even though for premature ovarian insufficiency, this has not yet been adequately demonstrated. So that's being extrapolated for menopause. And routine inquiry about sexual well-being and sexual function and how that correlates, especially for women with their social, their self-esteem and themselves as complete human beings. And the possible detrimental effect on cognition should also be discussed when we're planning hysterectomies and oophorectomies for patients who are under the age of 50, like I mentioned, for breast cancer. What are the interventions that we usually offer before we get to treatment? A balanced diet. I want you to imagine an 18 to 25-year-old, even yourself. I don't want to ask people in public on Slido what they used to eat, but we know. Adequate calcium and vitamin D intake for those who are living in countries where there's not enough sun, particularly. Exercise, I put that picture there just to remind even ourselves as clinicians that when we discuss exercise, we'd like it to be weight-bearing so that you can increase the load on the bones. And smoking cessation as well as avoidance of excessive alcohol intake. Alcohol has been not contraindicated, but related to severity of vasomotor symptoms for menopause. So that's an important one to know. And vaping, I've put that in question marks because I recently sat at a table where people from the West dared to say that this is a westernized problem. Whilst I've been to Nairobi recently, and I know you guys are catching up really quickly on all these Western behaviors, including vaping. We don't know what that is going to have, what impact that is going to have in the long term. I can't imagine that it would be a positive effect. Treatments for premature ovarian insufficiency are actually at the moment fairly straightforward because the problem is estrogen, then we replace the estrogen. But we have not yet found what works better. For example, we've always used low-dose combined pills, which have estrogen, and they also confer contraceptive, protection for these women. But they may be less effective than HRT in preventing the long-term outcomes, which is what is a public health aspect of things. There's a trial that is currently running in Europe called the POI trial, and we hope that we'll be able to answer that. But in essence, the treatment is replace the estrogens in whatever way that you would like to, whether it's a pill or HRT. Now I bring this with special issues. As part of our series, there will be someone else, I think next week is presenting on HRT practical prescribing. But I put this here because just to raise the special issues. There's no increased risk of breast cancer. And I want to raise this because myself, maybe younger people not, but myself and my seniors were in the era where the Women Health Initiative study came out and really caused us problems, saying that there was increased risk for breast cancer. That data has been reanalyzed and there isn't an increased risk. If you are going to get breast cancer, whether you take HRT or not, you will get breast cancer. For Turner syndrome, so Turner syndrome is abnormalities with the X chromosome. We advise that you give this throughout their reproductive lifespan. BRCA patients who I had mentioned before, as long as they've not had cancer problems themselves, once we offer prophylactic BSO, that's bilateral salpingo oophorectomy, then we can offer them HRT as well. Any patient who's having endometriosis, once we remove their ovaries, then we do recommend some low doses of hormones because we know that the progesterone sometimes can flare up the endometriosis if there's some that is still remaining. Anyone who gets migraines, hypertensive, someone who is overweight, these are not contraindications for HRT. And in fact, they can use transdermal routes quite well. The transdermal routes available at the moment are patches, and we do have gels as well. We do have sprays coming to the market. A lady who's had a history of VTE, I normally say discuss with a hematologist before you start, but we prefer to use transdermal medications. Fibroids are not a contraindication. And for anyone who is that category I talked about, the 18 to about 25-year-olds who've never had a period, then we recommend that you induce periods with 17 beta estradiol. So that's low dose estradiol from the age of 12, and add cyclical progesterones after that so that she can start bleeding or when breakthrough happens. So the initial estradiol is to stimulate secondary sexual characteristics. Fertility remains a big challenge for these women who desire to have children due to the ovarian function. And accepting egg donation, whilst it's a very good option, is quite a big ask for a lot of ladies because most people have imagined their own children. If you're having this conversation, I do like to tell my patients that there's actual studies that have been done looking at genetics. What genetics do human beings share with the other animals and even plants? We share about a 60% genetic matching with a banana. So when I found that out, then I started to reflect that myself, nearly 99% with the orangutan. But it's still a difficult conversation to have. And we do try IVF for some of these patients, even though it is usually not very successful. It gives the lady reassurance that she has done her best and it's not something that she would have been able to control. What is cutting edge? We are now talking about fertility preservation technologies, egg freezing, if we can, and especially for chemoradiotherapy patients. I know sometimes it doesn't occur, it doesn't come automatically for a pediatrician who has made a diagnosis of leukemia, for example, in a young lady, or even a physician who's sent their patient to an oncologist. But I want it to be forefront in our minds because these technologies are actually available even in the country at the moment. By country, I'm saying Kenya. They're still quite expensive, and that's our role to advocate for this to be offered in public sectors and for the prices to be brought down. But there's also ovarian tissue preservation, and that's sort of moving out of the experimental phases. You do need a pretty good lab to be able to preserve ovarian tissue. Very good for patients who are going to have chemotherapy and radiotherapy. And then there's a bit of work that's being experimented in terms of stem cells therapy. I put this slide, it is from the European Association of Reproductive People. So just to show how multidisciplinary, if I've not managed to convince you about multidisciplinary, this is just a quick snapshot: endocrinologists, cardiologists, geneticists, and then I want you to think obstetrics, surgical, physicians. It's a whole load of people. What can we do in the meantime to facilitate this? This is my call to action: to advocate for improved access to POI diagnostic tools and treatment, especially in underserved populations. They tend to get left out a lot of research. KNH has a research team, and I would really plead for them to be leading from the forefront in terms of that. Promoting the importance of patient-centered care. This I find very, very important. For me as a gynecologist, it's quite easy for me to think about the woman and periods. It comes quite automatically. But every time I remember when I've worked, for example, at Aga Khan, and a patient comes and they're in an accident, I'm not very sure, beyond the nurse, how many clinicians would remember to ask, when was the last period? What does your period look like? Did your mother go into menopause early? They don't come, those are not conversations that come, very naturally to all of us. So I would want us to be encouraged to promote the importance of patient-centered care. I remember one of my professors said, if any woman who is walking into your door is pregnant until proven otherwise. And the only way to know such things is when you ask about their periods. And I'd like to encourage collaboration and knowledge sharing between clinicians from different regions to address the unique needs for these patients. The fact that I have felt so honored to come and share this information with you is stemming from my understanding also of attending a conference where a Chinese professor presented something, and it made me start reflecting and thinking, oh yeah, I do see that in my practice, and I know that Kenyans also always ask me these questions. So we are going to end it there. I know I've spoken a lot. There'll probably be lots of questions. I hope it was not too heavy and intense. And I'd like to remind you that there's a feedback link that will be shared by Muthoni, but I'll hand it over to her. Thank you.
Thank you very much. Thank you very much, Dorcas. Dr. There is a question here so Stephen says, very informative talk. By how many years does TAH bring menopause sooner?
So that's interesting. We are looking at that data at the moment, and I think what we have presently is nearly 3 to 4 years. So if you think about, she would have had period menopause, she would have gone into the menopause at 50. You do her TAH at 45. You're in essence by age of 40. You do have her TAH at the age of 40. She may be getting into menopause by 45 rather than 50. I do want to disclaim as well that this age of 50, 51 is also a very Western age. We are working hard to produce our own work. We do know that African women of African origin, in where these studies have been done, are getting menopause earlier. The Asians are getting it even earlier, so between 45 and 46 years old.
Thank you very much. Dr. There's another question, and this one goes, what is your advice for ladies with Müllerian degeneration?
Sorry, malignant or Müllerian?
Müllerian degeneration.
Oh, Müllerian degeneration. So my
Yes.
advice is, if you are not working together, then I'd say refer. These patients are not patients that you manage by yourself. There's so many other aspects beyond that. And I know where that sort of question would come from. We used to see them a lot in Kenyatta, and I'm curious, I don't know where they used to go, because we'd see them in the ward, and the diagnosis would be made with do laparoscopy. But then I was in training, so I am quite curious to see where they go. Yeah.
Yeah, thank you. And the questions are coming. And
Yes.
Thank you very much for the questions. Excellent presentation, Doc. Does BTL affect age of menopause?
Very interesting. I want to say yes and no. Yes, because I cannot explain, or let me say, how do we do it? People do BTLs differently. Let's start there. So you'll find there are clinicians who will do BTL by removing the whole tube, which is salpingectomy. They'll remove the whole tube. And there are people who will do what we traditionally do as a tie technique with about 2 centimeters and close it in. So if you think anything that is coming close to ovarian blood supply, it can affect what is happening on the ovaries. So just go back into your anatomy and look at how you do your tubal ligation. Now, nicely done tubal ligation should not bring premature ovarian insufficiency, because we tend to avoid, and we do them in the watershed areas. And I wish I had like sort of diagrams to sort of revise that with guys who have not done BTLs for a long time. But we tend to lift the tube away from the vasculature and tie on both sides and cut in the middle, just so that we have something to report for histology. So that in itself should not put the lady in premature ovarian insufficiency.
Thank you. We keep coming. Questions keep coming. On to the next question. When is hormone replacement therapy advised in POI?
So as soon as you make the diagnosis, and that's a very good question, because part of the problems that we have is we cause delay in that diagnosis. I say we as clinicians and we as patients ourselves. So if you think about how patients are presenting to you, patients are either self-diagnosing over the internet. They read and they see that their periods can be irregular because, say, they have thyroid problems, or they're even stressed. So they don't come to discuss this with you. Discussing periods may still be a taboo for some people. They go like, yeah, we talk about periods. And I used to see a lot of patients, girls, very traumatized in the GOPC when they finally are brought to have a diagnosis because they've never had a period to the age of 21, for example. So educating our moms and our women to keep having the conversations about periods, that's important. And then for clinicians, when someone comes, actually we must look at women from head to toe. The fact that she has come with her hair falling is not always thyroid abnormalities. Think as broadly as you can, because you may be the person, it's not necessarily a gynecologist who would pick up premature ovarian insufficiency. If you're going to be having chemotherapy or radiation, then start to think in advance and even put a plan in place, even though you can't, even if you're not able to prescribe the HRT, putting a plan in place for that lady to be seen by a gynecologist so that it's instituted as soon as possible. The current evidence that we have is that there's a 10-year window within which we want to start HRT, even for the ladies who are older. So the earlier you make the diagnosis, the better it is for the patient. Whilst I'm on that, I'd just like to add that I'm really proud to, and probably KNH will announce this by themselves, but Kenyatta National Hospital has, I think, is due to start or has already started the first menopause service, and I believe that's in East Africa. And it sits nicely next to the fertility clinic. And part of the work that KNH has been then tasked to do is create multidisciplinary teams so that you can have this type of conversations within the hospitals. Thank you.
It is great to be a first of many. In your own practice for POI, do you tend to use COCs or HRT?
I like that question. Very nice. I give the patient the options, actually. So that's how I solve. I'm very pro-patient decision and patient involvement. I mentioned patient-centered care. So I give them the evidence, and the evidence is you're still going to replace estrogen in either way. If I give you HRT, there is the likelihood that you can actually conceive whilst you're on HRT. So if a lady is telling me, oh, no, I have no business getting more children, I already have my children, or I never wanted children anyways, then I put them on the pill because it's going to supplement the same. The only thing now we are doing within the trials is to see, does that low estradiol level confer the same benefit in protecting hearts and bones? So the study, the POI study trial in which I'm involved, we look at their bones and we look at their estradiol levels. Every 6 months, bone densities are being done every year, and we'll probably have an answer on whether we shift more towards HRT or more towards estrogen. But my patients choose what they would like to have. And they also choose the route in which they want to have. So for example, even HRT, they can have tablets, they can have pills, they can have patches and all sorts of things. They can spray in their mouth, they can have an implant. So I let them choose whatever they like.
True practice of person-centered care. Thank you. This is a very interesting, this is a comment. TAH induces menopause. This is new. What's your comment?
Oh, yes. I was how many years old? Very recently, when I started reading more into menopause and premature ovarian failure. Yes, there is evidence that the TAH, whether you remove the ovaries or not. So when you remove the ovaries, definitely. Whether you leave those ovaries, the theory is just the interference of ovarian blood supply. So yes, as surprising as that may sound, yes, they do get into menopause earlier. Whoever has asked that question, if you could get in touch with me somehow, or send me your email, I will share that paper with you.
Great. Excellent presentation. What should be our index of suspicion in patients with children who present with suggestive symptoms of POI?
Very good question. Any woman. So I know I said every woman is pregnant until you prove them otherwise. My new thing is every woman has some hormone problem unless I have proven that they don't. And I get, I used to get a lot of slack at Aga Khan Hospital because every woman would literally get my question, when was your last period? And maybe it's just because of my interest in women's health. It didn't matter what you presented with. When was the first day of your last menstrual period? As soon as she answers that, then it triggers me to start thinking. If she says it was yesterday, it was last month, it was last week, it was within a month, then I have no problems. Anyone who has missed a period for a month, I investigate. So very high index of suspicion. And I don't wait for the patient to tell me she has menstrual problems. I tease it out of them.
Thank you. Now that estrogen is important for bones, what are we supposed to advocate for young women than hysterectomy when they are below 40 years?
So the conversation to have when I do hysterectomies or anything, even if I'm going to touch the ovaries, endometriosis, whatever surgery, is to have those conversations of the possibility of, because you don't know if it's going to happen or not. Once we've done the surgery, I usually recommend 4 to 6 months, do an estradiol level check. That gives you a fairly good indication of what's happening within the ovaries. The FSH may take a little longer, but within 6 months, you should have a good idea what her FSH levels are looking like. So I don't send the patients away just because you've solved their fibroid problems and they're no longer bleeding, because that's how we lose them. By the time they come back next, they have had hot flashes, they're not sleeping, they're anxious, they're depressed, and all sorts of things.
Awesome. HRT predisposes to adverse effects. So what's the advice for long-term users?
I'm curious to know what particularly adverse effects or side effects you would be having in mind for the person who's asked the question. I say all medications have got side effects. With HRT, there is a list and there's a grading system that you do before you start anyone on HRT. And part of those things are like, for example, the BRCA genes, VTE risks, previous family history of early arterial diseases, diabetes, hypertension. There's a whole load of quite a big checklist. So then there are people who will never be able to have HRT, which is unfortunate, but there's luckily research that's ongoing. So for example, for our breast cancer patients, there is a product that has just come into the market, maybe about 2 years in the States. It's just being rolled out in Europe from December. And this is a brain receptor modulator that helps to reduce their hot flashes. And that seems to be quite effective. So there's still a lot of research that's ongoing. A patient who has risks, you don't give HRT. So the people who are getting HRT are people who actually have no risks and need the HRT. I'm not sure if I've answered that question. I may have rambled on a little bit there.
I have a very long list of questions coming your way. What advice can you give a lady with POCs?
Now, POCs is products of conception. I want to presume they mean PCOS, but that is an assumption that I am making. If they have POCs, they should go to the gynecologist and have an evacuation of the uterus. If they have PCOS, they should, in essence, be seen by a gynecologist and an endocrinologist, because it depends on what symptoms they are presenting with. What is it that is disturbing them? What is the problem? So they end up with gynecologists when they're having problems with periods or they've been trying to conceive, infertility. The endocrinologists will usually be the people who sort them out in terms of their hormones, things like HbA1c, insulin resistance. That's usually an endocrinologist. And now I love sending my patients to dermatologists as well, because lots of these ladies will be complaining about acne and too much hair. They're not even interested in this baby making process of mine.
I will combine the next two questions. So one question is a bit long. So the question is, my mother is 53 years of age and has been experiencing hot flashes and palpitations. Was on Estovon tabs, but currently not locally available. Switched to isoflavones with no improvement. Would you recommend use of gabapentin for the hot flashes? Or which medication would you recommend for her? And my other one that I will combine with that one is very informative. Where do you practice and how do we refer to you? Many people are suffering for lack of knowledge.
Yes, don't I know it? So 53-year-old with hot flashes was already on HRT and now is not. We do have products that are available in the market in Kenya, and we are really pushing. Part of why we've had this conversation for the whole of October, and we'll continue this all into November, is because if we don't create the demand, or if we don't, as clinicians, know what is required, then people will not be able to supply. So, for example, I'm not very clear on the KEMSA role in HRT procurement. I'm not sure if this is available. I know that there's HRT, but how it comes into the country, no idea. So, but there are other products that are available in the market, and we are pushing the people who have these products to be able to facilitate and bring other options. So, for example, about 6 months ago, it was going to be very difficult to get patches. There were no gels in the country. I'm now made aware that these are available, even though you have to give an arm and a leg. So we are hoping that the more we talk about it, the more people need it, the more demand will create, and therefore ease the supply. Now, I would suggest she goes on HRT. Dr. Wende, who is leading the Kenyatta National Hospital Gynecology department, is a keen menopause enthusiast, and she would be able to sort this patient out. So if you send them looking for Dr. Wende, that clinic should be up and running fairly soon if it hasn't started. So she will be able to get some HRT on board. If she's used HRT and has had good effects, it's unlikely that things like isoflavones and gabapentin, stuff like that, would help. But you would be surprised that a lot of times to get a thing that fits, that's not necessarily HRT, takes trial and error. And that's one of the things that we have to counsel our patients, that it's not, I'm not going to give you medication and then everything will be fine. We may be able to sort whatever is your biggest problem, and then some of the other things we may be able to supplement. So isoflavones, which are fairly, straightforward to use, not a big problem. Gabapentin should require prescription, and I am not sure if it would work or not work. She's got to try it, and then we see whether it helps or not. And it may be because her problem may be just the hot flashes, then she doesn't need anything else additionally. Where do I practice? I'm currently in all over the place. So this is usually, and I know Muthoni is just laughing. She can imagine what I'm going to say. I have a practice that we run with Dr. Wende at KMA Center, room 304, and Kenyatta Doctors Plaza. That said, a lot of my patients would now be easy to see online, just because I'm traveling quite a bit. So I am available. You can get me on social media platforms. Kenyatta has got my details, and I'm more than happy to see patients. That said, because I'm an empowerer of other people, we do have a team of about 10 obstetricians and gynecologists in the country at the moment, with whom we are running this series between October and November. And we'll probably share the details of those people, because there are people in Nairobi who have this information as well. The ones who will be presenting next week definitely are based within Nairobi.
Great. Are there any studies on the effects of BTL on libido?
That's a good one. I always say that it doesn't affect libido, because technically it shouldn't, unless, again, it's been done so chaotically that you have wrecked the blood supply to the ovary. And I haven't seen any studies into that. It's a good question. I know my patients are always asking, but I haven't looked into it, and I've put that down to check.
Great. I think you talked about this during your presentation. HRT versus CA breast. What's your take when managing patient with POI?
Okay, so yes, CA breast confirmed, we don't even touch them within a mile with any hormones. So remember, CA breast, the bigger problems, and we are having a talk actually on the 4th of November with a breast surgeon. She works at KNH. You might know her, Dr. Mary Lenomondi will be presenting. CA breast issues is that they're estrogen or progesterone or both dependent. So we don't touch them with HRT. They are quite a complex group of patients, and those are part of the people whose studies are running quite actively in how to manage their symptoms. So that's the difficulty we have. We do have complementary therapies, and part of what people have discussed here, things like gabapentin, St. John worts, soya-based injection tablets or medications or even foods, because soya is a phytoestrogen. Again, that with a bit of caution because of the estrogen components, but they're one of our most complex groups because it's not just the breast cancer, it's the treatments that go alongside it, the chemo, radiotherapy, and whatever they get afterwards in terms of tamoxifen and controlling their symptoms. So yes, very complex, very difficult to handle, and sometimes very sad to see these patients. I do feel, however, when we talk about patient-centered, explaining to patients all these things, including what we know and what we don't know, makes it very easy. So they don't feel like they're just searching around for something that may or may never come, and they get very disoriented. So I do tell my patients, we don't have the evidence for that, or we do have evidence for that.
Awesome. A 39-year-old lady, para 2+2, not on any contraceptives for over 5 years, non-hypertensive, BMI of 42, regular periods, smoker, no comorbidities, has not been able to conceive. How can this patient be helped?
Well, a couple of things. Did you say BMI of 42?
Yes.
Hey, she could start. I've even made a noise that normally I shouldn't make, but she starts off with lifestyle changes. She has too much going on. Smoking in itself, it affects ovarian function. It makes the ovarian function drop, and quite dramatically. And even where the ovarian quantity, in terms of the test that we do, if the quantity is not affected, the quality is definitely affected. So we do have young patients, 25, 30s, poor health, smokers, eating lots of not very good foods. Even when we have done IVF, you can collect nearly 20 eggs, and then you find one embryo or no embryos because they don't get fertilized, they don't produce very good embryos. So please ask her to stop smoking. And then BMI can have an impact on just even how we release eggs, ovulation. Her BMI needs to be at least less than 30. Even if not for getting children, just for her general well-being.
Great. And that also includes supporting her with smoking cessation.
Yes, yes.
Is it advisable to start hormone therapy to prolong menses?
To prolong menses?
I'm not sure if that was supposed to be for prolonged menses or to prolong menses.
I wouldn't imagine anyone on the face of this earth who wants to prolong their menses. So I'm not clear how to answer that. That said, HRT not for menstrual abnormalities or conditions. We don't use HRT as a means to interfere with periods for whatever reason. There are other ways to play around with periods and when you want to bleed and not bleed for whatever reason, but not HRT, no.
There is a lot of interest and questions around PCOS. And there's this question about PCOS is associated with irregular menses. Is this a sign of POI from your talk?
So I think I alluded to that. I'll repeat for the person who's asked the question. PCOS and POI can have similar presentations. The differences come in the biochemical tests. So in PCOS, FSH, LH, and estrogen are high. So remember, PCOS, they are not ovulating regularly. They've got loads of ovarian, the follicles. They have a lot of them. So the estrogen is high. POI, there's no ovary activity. So FSH will be high, LH will be high, but the estrogen will be low. But everything else, they behave the same.
Thank you very much, Dr. Ari. We have had a great session. And I would like the participants and all of us to know that there is a screening today for a documentary on menopause called The M Factor. If you're within Nairobi and its environs, it would be great for you to attend. And actually, it's also showing online. You can join the watch party. So Dr. Ari, I would like you to have to summarize today's conversation.
Thank you so much, Muthoni. I probably want to appreciate that you will be talking to us in the near future about lifestyle modifications and adjustments for menopause. I'm very excited. I can't wait to hear that. For anyone who would like to continue to engage with us and listen to the whole of this series, we've got something running every week all the way until the 25th of November. So with the feedback form, I'm not sure if the link was put. Muthoni, did you manage to put the link?
Not yet.
Okay. So if you can put the link for feedback and please answer on there. If you're interested in having and following these conversations, then you can put your email address on the link, and that should be, we'll give you more information. But thank you so much for everyone who has shown interest, who has attended. Please put on the feedback form anything else that you would like to hear from us. I'm hearing a lot of PCOS, and even though that's not related to menopause, it is about hormones, and I will ask the KNH team probably to give me another session and we can discuss PCOS in terms of that. I'm waiting for Muthoni to share the link. I don't know if I have it myself. I might be able to share it. Link address, and I have put it in the chat for anyone who needs to do that.
Great. Thank you very much, Dr. Ari. If you can, the form is on the link. Kindly fill in the form. We are happy to engage and continue with this conversation. And enjoy your weekend in the meanwhile. We will leave the room open for a few more minutes to allow us to provide feedback on the form that has been shared. Thank you very much. And we see you next week on the next webinar. Thank you.